And some other reminders as we move forward with our meeting. Please mute your line if you're not speaking, but remember to please not mute the FSSA line. I am unfortunately remote today, so my apologies for that. So you won't be able to mute me, but you will be able to mute the room. So please don't mute them. Good morning, Dr. Anderson. And as a reminder, we'll go through roll call voting when we get to the times where we need to vote. So you can do aye, nay, or abstain when we get to those portions. And at public comment, I will ask for public comment, and you can shoot a message in the chat box, raise your hand when we get to that portion of the agenda. And we will go through and I will help us drive the agenda. So with that, I will then start us off with Ms. Lugo for the call to order and opening remarks.
Thank you. I call the meeting to order. No opening remarks today. Just thank you everybody for your time.
Thank you. Next item on the agenda then is the approval of the minutes. So we would need a motion and a second for that.
Can I have, what are we doing, minutes? Can I have a motion to approve minutes?
Approve minutes, please. I'll move to approve. This is Carol.
Second, anybody?
I'll second it, Dr. Andreessen.
Thank you. All right, so we have a motion and a second, so I'll start with our roll call voting. Ms. Lugo.
Oh, sorry. I'm sure I'm reading email and approve.
Did you say, I'm sorry, I missed that. Did you say aye, Ms. Lugo?
Yes.
Okay,
Aye.
thank you.
Approve.
Dr. Andreessen?
Approve.
Dr. Holvershorn?
Approve.
Dr. Knapp?
I approve.
And Dr. Ott?
Approve.
And Dr. Powell?
Approve.
Any other members of the board or the committee joined that I maybe have not called on yet that joined after the fact? I just want to make sure I capture everybody for voting. I don't see anybody, so I think I'm good. All right, so we have all ayes, so that motion will carry. Thank you. So then we will go on next to our utilization update. So for our utilization edit recommendations, we have a new product, Zurzuvae, and it comes in a 20, 25, and 30 milligram capsule. It's for postpartum depression. We have the utilizations at 18 years of age and older, a PA required, and then for the 20 and 25 milligrams, it's 28 capsules per 365 days, and then for the 30, it's 14 per 365. Any questions or comments on that? If not, if I could get a motion and a second, please.
So moved. This is Wendy Powell.
This is Carol.
Okay, so we have a motion and a second. Ms. Lugo.
Aye.
Dr. Andreessen.
Aye.
Dr. Holvershorn.
Approve. Is that what we're doing?
Yeah, you're fine. Yes. Dr. Knapp.
I approve.
Dr. Ott.
Aye.
And Dr. Powell.
Aye.
All right, so we have all approvals, so that motion will carry. Thank you. Next, we will then move on to some of our PA stat review. And you may remember from the last meeting, we had some discussion about having some updates on the way we're presenting our stats and some additional information. So we do have some new things to go over today. The first item, though, is something that we always discuss, and that is around our overall PAs for our mental health agents. So you can see overall in Silonath, we had a little over 38,000 that went through with just shy of 30,000 approved and a little over 8,000 denied. And then of those, you can see those that went to the call center, and then those that were approved by the call center that never went through Silonath, meaning they obtained a PA either through e-prescribing or something like that prior. So in the next slide, you will see our graphic. And this graphic is something that we put together to match kind of with the MCE graph. So on the left-hand axis, you have the number of PAs, and then on the right, you have the approval percentage. So the approval percentage is followed by the lines. The PA volume is in the bar chart. And so you can see the antipsychotics are in that greenish color. The duplicate SSRI, SNRI are in the orange. Duplicate stimulants are in kind of the purple color. In the pink is the duplicate SED hypnotic benzos. And then overall, all of those together are in kind of the aqua-y blue color. So you can see overall trending over time, we've been fairly steady as far as volume goes. You can see there is a slight kind of increase in the approval percentage in the duplicate SSRI, SNRI there in the last quarter, where that line kind of goes up a little bit. I just think that that's likely a cyclical thing with the us removing the bupropion. Thank you. I was thinking of the word there. So that I think is a cyclical approval there. So I think it'll likely steady out again. All right, then moving on to the next slide. So we have our age review, and this is new. So we capture this as the age as of 10/1, so kind of at the beginning of that fourth quarter. And this is our antipsychotic review. So you can see under 3, we have no utilizers. From 3 to 5, we do have 33 individuals. And then 6 to 12, you could see the little over 1,000, little over 1,600, and 13 to 17. And then by far the bulk of our utilizers are in the 18 to 64, and then just shy of 400 in the greater than or equal to 65. And then on the stimulants, again, under 3, we have 0. 3 to 5, we have 91. And then you can see the bulk is in that 6 to 24 years. That's where the majority of our utilization is. We do have a little bit of utilization in the 25 to 49, and then it definitely tails off once we get to 50 to 64, and very minimal in the greater than or equal to 65. Any questions on those new age statistics? All right. For adherence measures, this is from second quarter. So I just want to point that out. We're always going to be about a quarter behind with these, just in the way it takes us to load the data. So for depression agents, we had an 88.5% adherence, which was just a slight increase from the last time that this was measured. And then the psychoses agents was at 89.4 adherence, which is a slight increase from the last measure as well, which is really, really great adherence rates that we're seeing on the fee-for-service side. The managed care entities will be providing their end in the next meeting, and I think that will be a little more telling just because we don't have more of our patients shift out and in, and so I think it'll be interesting to see kind of where their adherence is. But overall, what we're seeing is really pretty good from our standpoint. All right, and then in our PA stats related to addiction, we did update a few things here just so you can see them. So the first one we've always had, which is our buprenorphine paid claims. So you can see we have been on kind of a steady rise on the buprenorphine naloxone, which I think is good. I think that's related to likely the XDA waiver being removed, additional people gaining access. You can see the plain buprenorphine is in kind of the greenish color down at the bottom, and then the buprenorphine long-acting injectable is in the orange. It's still very low, but they were just recently added to preferred with PA, the Sublocade was. So I do think we may see that shift up just a little bit as time goes on. Then on the next slide, so here's kind of our newer measures that we're starting to track. So these are the unique members. And you can see, again, kind of just a slight increase over time of unique members that we have on the buprenorphine naloxone. A little bit of a decrease in the buprenorphine, which I know that changes quite frequently because we tend to have more pregnant members that use the buprenorphine and some other individuals there, so that can kind of fluctuate. And on the next slide, our unique prescribers. And so again, just a little bit of a slight increase, so I think we are seeing a little bit of an increase on our end. And then keep in mind, we have a pretty small number of individuals that we're looking at. On the next slide, I did do a breakdown that we probably won't do every time because I don't know that it provides a lot of value, but I think for this initial review, I think it does give us some value to look at. So when we were looking at the unique prescribers, what we did is pull over taxonomy and prescriber type. So keep in mind, this is reported by the prescriber as their taxonomy. Sometimes they have more than one and we only see the first one. So there may be some people that are bucketed in an area that could be bucketed somewhere else. But I do think that there's a couple of things that are really interesting to note here. One is our ER and hospitalists and OBGYN prescribers is, in my mind, exceptionally low. When we think about, I hope our OBGYNs are always asking to treat and looking at treating, but that's a really low number of prescribers overall, as well as the ER hospitalists. We're trying to encourage ER prescribers to initiate therapy, especially as they come in with an overdose or at least have that conversation. So that number is, I think, kind of low. The other thing that I think is interesting in the general medicine and other, probably a good 8% or more are all nurse practitioners in this group. So it's general medicine nurse practitioners as well as kind of like adult medicine nurse practitioners. So I found that to be really interesting as well, that the nurse practitioner number is so high in comparison to other prescribers. Now I get that's likely reflective of, we have less prescribers and more nurse practitioners, but it is a very high number of nurse practitioners that are prescribing buprenorphine to patients over some of the others. Any question? Oh, and I just saw your comment, Dr. Holberstern. You're saying OBGYNs are normally nurse practitioners?
No, that outpatient buprenorphine sort of focused practices, they tend to almost exclusively employ like family nurse practitioners. And their sort of addictions, that's what they do, is they prescribe buprenorphine to people with opioid use disorders. That's their business model, and that's typically who they employ. So I'm guessing that, like, they're not, I doubt they're mainly like in family medicine offices. My guess is they're largely in OBOT offices.
Okay. That's good to know. Any other comments on this or any other thoughts? I thought it would be good to kind of level set to see where we're at on prescribing, and then in the future we can look at this again to see if we've made any movement in other areas or if we feel like we need to make movement in some areas. But all right, so for our next slide, then this is just our trending of our PA requests. Overall, we have very small numbers of PA requests in buprenorphine. So you can see our approvals are in the green, the totals in the purple, and then the denials are in kind of the orange. Most of our denials are related to a non-preferred product and just having them utilize the preferred agent. So a lot of times they just end up switching over, they don't know. But we don't have PA on our preferred agents. So truly this is just related to utilization of non-preferred agents or in long-acting injectables as well, which is still a very small number of requests at this point. And that is all I have regarding our new statistics. We are still discussing some other things that we will be bringing back to you all, but any questions or comments or anything about the new data? All right. Well, thank you for that. I will then move it along to Ms. Lugo. I believe, or is Ann? Dr. Kuhn will be providing today the long-acting injectable antipsychotic data.
So good morning, my name is Ann Kuhn. I am one of the pharmacists with the Office of Medicaid Policy and Planning, and today I will be discussing 2022 IHCP claims data related to long-acting injectable antipsychotic therapy. So at our last Mental Health Quality Advisory Committee meeting, updates to the MHQAC reporting were proposed, and during that discussion, requests were made for information related to long-acting injectable antipsychotic therapy. This included general utilization, specifically that of LAIs at higher strengths, information on current use of same agent, long-acting injectable and oral antipsychotic therapy, and LAI-related adverse events. So jumping into the claims information, in 2022, there were a total of 674,227 antipsychotic claims, of which 34,453 were for long-acting injectables. Of the long-acting injectable claims, 10.6% were for first-generation agents and 89.4% were for second-generation agents. Now looking at the unique member utilization, we had 92,235 members with a claim for an antipsychotic in 2022. Of those members, 4,820 or 5.2% had a claim for an LAI. We had 483 unique members utilize a first-generation agent and 4,419 members utilize a second-generation agent. As with the claims data, significantly more members utilizing the second-generation products. And then here we have the claim count breakdown by LAI agent. With claim counts, it's important to note the frequency of administration. So some of these agents are administered biweekly, some monthly, all the way up to the every 6-month half year up. Additionally, some formulations require a loading dose. So these are factors that can drive a claim count up or down. In 2022, the majority of claims were for paliperidone products, followed by aripiprazole, then haloperidol, risperidone, fluphenazine, and then very little olanzapine utilization. And then in this slide, we have the breakdown of unique utilizing members by LAI agent. For this information, we don't have to consider the dosing, but we will have members shift between agents and potentially be counted multiple times. Here again, we're seeing the same utilization pattern with paliperidone as the most utilized and then olanzapine least utilized. The next several slides will illustrate claim count and member utilization for each of the second-generation agents by formulation and strength. In general, we have more claims and unique member counts in the higher strength of each formulation. We do have a couple exceptions. One here with the Aristada, it's kind of unique. We have more claims and member utilization for the 882 milligram strength versus the 1064 milligram. However, the 1064 milligram strength is administered every 2 months versus the monthly 882. So the higher strength injection is actually the conversion for members on the lower aripiprazole oral dose compared to those on the 882 milligram injection. Here we have illustrated the very minimal utilization of Relprev. And then this slide includes claim and member data for the paliperidone formulations and strengths. The bulk of IHCP utilization is here with the Sustenna products. And again, in the higher strengths, having higher claim and member counts. If we did want to try to tease out the loading dose, there were 398 members that had only one Invega Sustenna 150 milligram fill, and 322 members that had only one 234 milligram fill. However, because it's a 2022 snapshot, not everybody's initiating therapy, and there could be single fills that were maybe ends of therapy too, something like that. And then formulation strength breakdown for risperidone products. Risperdal Consta is the other case where we had more utilization in the 25 milligram versus the 37.5 milligram. So an exception to that trend of greater utilization at the higher strengths. So switching gears here, now we're going to look at concomitant use of long-acting injectable and oral therapy of the same agent. Our data pool included cases in which a member filled a 28-day supply or greater of an oral therapy that was the same agent as a previously filled long-acting injectable during the period which the LAI would have been active. So basically it's day supply. So there were 1,987 claims for a same agent oral antipsychotic therapy filled during that kind of active period post LAI claim. These claims were associated with 576 unique members, which is 11.9% of all LAI antipsychotic utilizers. This concurrent utilization most frequently occurred with aripiprazole agents, but paliperidone was not far behind. And then on to the adverse events associated with LAI antipsychotics. For the first data pull, we requested inpatient, outpatient, and ER medical claims that included ICD-10 codes beginning with AG2 or R25 within 90 days of a long-acting injectable antipsychotic claim. So initially we had a list of ICD-10 codes that we were interested in, but those ended up pulling nothing. So we had to kind of go about it by pulling everything and then excluding. So some of the diagnoses that were excluded were restless leg syndrome, Parkinson's disease, idiopathic orofacial dystonia, and fasciculation. There were 67 unique cases involving 57 members. So a unique case would be a specific member, LAI agent, dose, and diagnosis kind of combination. There were 16 ICD-10 codes that pulled, excluding those previously discussed that were associated with 5 LAI agents, including 6 formulations. The most frequent diagnosis codes were drug-induced subacute dyskinesia and extrapyramidal and movement disorder unspecified. As illustrated in the graph, paliperidone was most often associated with an adverse event diagnosis code. And it was the Invega Sustenna 156 and 234 milligram that had the greatest number of adverse event diagnosis codes associated. And then next we looked at initiation of a movement disorder agent after an LAI antipsychotic fill. So here, of those that had an LAI claim, we looked for members that had a fill of at least a 28-day supply of a movement disorder medication, who had no previous movement disorder claim history with a look-back period of 2 years. We found 274 unique cases, so this would be a specific member LAI agent strength movement disorder agent combination. Of those cases, there were 63 members identified as affected. There were claims for 6 different LAI agents prior to the movement disorder claim, and the pool included 6 movement disorder medications. We did exclude propranolol and diphenhydramine due to the high likelihood that a member could potentially be utilizing for a different indication. Claims for benztropine were by far most common movement disorder medication that resulted. And then, as illustrated in the graph, claims for LAI, paliperidone were most often observed prior to the claim for a movement disorder medication. And again, it was the Sustenna 156 and 234 that most frequently had a subsequent movement disorder claim. And then just to kind of sum up what we've gone over, in 2022, long-acting injectable antipsychotics made up 5.1% of all antipsychotic claims, and these were most often for second-generation agents. 5.2% of members utilizing antipsychotic therapy had an LAI claim, and paliperidone formulations were the most utilized, making up 50.7% of all LAI claims. In general, across agents and formulations, higher strengths were utilized more frequently by more members. 11.9% of LAI antipsychotic utilizers filled a concurrent prescription for oral therapy of the same agent, and that concurrent utilization occurred most often with aripiprazole, but also frequently with paliperidone. Adverse event associated diagnosis codes were more commonly linked to the higher strengths of a formulation, particularly with long-acting injectable paliperidone. And then 1.3% of all LAI utilizing members had a new claim for a medication to treat a movement disorder after a long-acting injectable antipsychotic claim. And this was most frequently following a claim for a paliperidone long-acting injectable. So kind of a lot there to digest. Didn't know if you had any questions. I have a very, very long PowerPoint that goes way more into detail. If anybody's interested, I can send that out, but all right, thank you.
Hey, quickly, I'm sorry, I couldn't get off mute. Amanda, hey, Ann, this is Beth McCarty. I would love to have your longer PowerPoint.
You got it.
Thank you.
Sorry,
Amanda.
Can I ask a question too before we move on? What do we have? We're not able to do any edits on oral in IM. Do we do those currently?
We currently allow
Allow it.
through our silent off
processing system, but
Okay.
if that's
Yeah.
something that we think we
But that's if
Sorry.
they're the same chemical entity. So if they're trying to
Right.
get a different
Entity
chemical
we allow.
entity.
Because we're assuming that they're doing an oral and IM overlap.
That's our
Okay.
assumption currently. yeah.
Okay. But not that they're, okay.
We do have some individuals too that end up doing oral, like their injectable towards the end of the month or whatever seems to wear off for them. So they end up doing like a week of oral with it or something like that. And then they do the injection again if they're not doing the injection earlier. We've seen that occasionally as well.
I did wonder too, how many are unintentional, like maybe on an autofill and the pharmacy is unaware of the injection and then, I don't know, that could be a big case too.
Thanks, Dr. Kuhn. That was a great data set. We will then move on to our managed care pharmacy update. So first up, we have the group data. So who is the lucky one presenting our group? I see Brian going off mute. So I assume it is.
Hey, Amanda. Yeah, can you hear me okay?
Yes, we can. Thanks.
Great. Good morning, everyone. Brian Musio with MDWise for the MCEs and this buprenorphine data. So this first slide here is the buprenorphine claims volume, just kind of showing you graphically the last two measurement periods. And you sort of see this, slow decrease, minor decrease across here. But I want to point out at the bottom of this graph set, the addition of the Brixadi and the Sublocade, the injectable products at the bottom. And so you do see some movement in those classes across the board. So we did have some uptake of those items in this measurement period. So we'll begin to see a little bit more trend as we move out further and look at this going forward. Again, just that slight decline across the board, and nothing unique about that. So next slide, please, Amanda. This one is the unique members, and again, you see a similar pattern, sort of this little bit of a decline across the board. United pretty steady, but again, their population is a little smaller. And then I do like to point out that the graph scale on the United side on the far right is a smaller scale. So relative, that graph is smaller. And again, that same slight decline in members. I don't know how much this is related to the redetermination process, but we'll see how that goes. And next slide is the prescribers. And you'll notice an increase in this one almost uniformly across the board, but it's almost all related to the Brixadi Sublocade at the bottom. The new prescribers into these pools are related to those two agents almost across the board. So we do see that increase all the way across. And slide 4 for the buprenorphine PA requests. And again, I'd like to point out here, we're looking at very, very small numbers relative to the numbers of claims. The PAs are only done for those patients that exceed the allowable dosages. And so we do see a little bit of an increase, but almost all that increase is related to the Brixadi Sublocade as well. So I don't know if anybody has any questions. I did want to comment, Amanda, about your thoughts on those NPs earlier, about them being high. I will tell you that Wendy and I actually did pick up on that same situation across our whole behavioral health prescribing. And we sort of feel like it's related to them seeing their primary care, right? Their physician, their psychiatrist, whoever else that might be, and then the NP continuing them throughout the therapy. So that's kind of what we attributed it to. But any other questions on the buprenorphine data? Thank you.
Thanks, Brian.
Uh-huh.
Next up, we will have Amy Berger with Anthem.
Good morning. Can you hear me okay? Excellent. All right, as Amanda mentioned, my name is Amy Berger. I'm the pharmacy director for Anthem. So here on the first slide, as in previous quarters, this is just going to provide those actual values for the fourth quarter. But what we are going to do is focus our attention on the next slide, which will show our trends. So here on our trends, we have the PA volume represented there by the bars, and the y-axis is to the left, and then the approval rates are represented there by the lines with the y-axis at the right corresponding. So the first class we start with are the antipsychotics, represented here in red. And we see that the PA request volume here remains fairly steady, and the approval rate is continuing to drop slightly, and that likely due to that removal of that 15-day supply for new starts. As we know, many of our members had requests for bypassing that 15-day, and those were approved. So remaining requests are really just for the duplicate therapy and other utilization edits we have in place. We then move to the antidepressants, which are depicted here in the orange. And here you may recall that we had shifted our duplicate therapy edit from a soft edit to a hard edit, so requiring a hard PA, and that's where we saw that uptick in volume in the second quarter, and then spiked a little bit there in the third quarter, but now we appear to be leveling off in that PA volume. And then similarly, we also have the approval rate that we saw that uptick, but now again appears to be leveling off. We then move to the stimulants, and that is shown here in yellow. And for the stimulants, as expected, we see a decrease in the requests when school's back in session. So for the fourth quarter, that's traditionally our lowest volume of requests compared to the other quarters. And then our approval rate, after that temporary little decrease in approval rate in Q3, looks like we've returned back to the approval rate we've seen in previous quarters. So we believe that is going to stabilize there. And then lastly, we have our sedative hypnotics benzos that are represented there in the green. And as you'll see, the PA request volume remains fairly steady for this class. And the approval rate, we are seeing an increase in this past quarter, and that was after that slight dip that we saw in Q3. Not exactly sure what we're seeing causing this. So we are going to continue to monitor that, but initial thought is that, as we had mentioned previously, we had several requests that had indicated that, yes, the member was tapering from one medication to another. So those were the short-term approvals. But when the subsequent request then came in, we did not see that taper reflected in the claims. So we think that maybe that has kind of rectified itself and we're seeing truer requests, but we'll continue to monitor that and have hopefully an update to that with the next quarter. Are there any questions today? All right then, thank you. Happy Thursday.
Thanks, Amy. Next up, I believe we will have Beth presenting with CareSource. Oh, you're on mute, Beth.
Of course, I'm the one. Hi, good morning, everybody. I am Beth McCarty. I'm the Director of Pharmacy for CareSource for the Indiana market. As Amy mentioned, what you're going to see is the MCEs have arranged our slides in the same fashion to make it easier to follow and to go through. So the first slide is the raw data that we'll be discussing on the next slide, which is the trend slide. So Amanda, thank you. If we could move over there. And as you can see here, just as Amy mentioned, we have our PA volume on the bar graphs, and then our trend line on our approval rates goes across. So again, just to set up for the committee and as a reminder, when CareSource came to the market in 2017 and we were setting up our duplicate therapy edits, CareSource actually set those up to be soft edits, to be allowed to be overridden at the pharmacy level. So throughout the summer and late third quarter, we actually coded and implemented hard edits. And you can start to see in Q3 where we did have an increase in PA requests due to the hard edits going into place for the different categories of medication. what I wanted to really, we're not seeing anything significant, but what I wanted to ask my MCE friends and fee for service is around the benzodiazepines, and then just also in general for prior authorization. I met with the head of our PA unit, and when we're looking at duplicate therapy and giving folks time to titrate off or say they're changing doses, are you guys treating those as prior authorizations, or are you going in on the back end, having the PBM per se just put in overrides to allow that claim to pay during that time period? Or are we count everything as a PA if it comes in. So that means we would go in and add a PA for a time period versus going into the claim system and putting in an override to allow that duplication to persist, as they're titrating them. So I just wondered, I wanted to make sure we're capturing our data in the same way. So Amanda?
We fee for service does it like how you do. It's a PA. So it gets written as a PA, captured that way as a PA for a short term.
Okay, great. Thanks, Amanda. Any of my MCE friends, and if you don't know off the top of your head, I totally understand that.
This is Amy with Anthem. Yeah, we do it the same way. They're
Okay.
short-term authorizations, but yep, captured as PA.
Okay, great. Brian or
Hi,
Wendy?
Beth,
Or
it's Cindy.
Cindy? Hi, Cindy.
With MHS, we do PA for short term.
Okay, great.
Same for UHC.
Okay, it sounds like we're in alignment. So what I did discuss with our head over our prior authorization is, we knew when we put in the hard edit for duplication of therapy of benzos, all of the classes, we're going to see this increase. What my concern is why we are so high on our approvals for that category in comparison to the other MCEs and fee for service. I know fee for service, I think you're running around 50-ish%. We're just much higher. So she has tagged this for an audit. The audit is scheduled to begin next week. They're going to be auditing all of the prior authorization requests that are coming through, and they're going to be auditing from a clinical quality and application of the criteria to try to see and understand what's going on. And based on what she finds, then what we'll decide whether or not we're going to do is then look at prescribers, any trending around that, or kind of what's happening to just try to understand, are these appropriate approvals, or do we need re-education, or do we have something kind of odd going on that we need to address? So I'm going to stop with there. I know I didn't go through each drug category. Does anyone have any questions or suggestions for me? All right. Well, thank you, Amanda.
Thanks, Beth. Next up, we have MD Wise, and is Nick presenting for you all?
Yeah.
Or who's okay,
Yep,
Nick, I
I'll
will
be
let you take it
presenting.
away.
Perfect. Thanks so much, Amanda. My name is Nick Rikas. I'm clinical pharmacist at MDWise. I'm presenting our stats for this month. So overall, PA volume, PA approval percent remains fairly consistent for us. Appears to be normalizing out with the end of the year here. Antipsychotics are leveling out following those first quarter changes that we saw. Antidepressants have also remained fairly consistent. We did see an uptick in the therapeutic duplication PA for stimulants. We are attributing that to the continued shortages that we're seeing, but we'll keep an eye on it and see how it goes. And then benzos have also remained fairly consistent. And to Best Point, MDWise also handles those similar to the other MCEs with the override placed with the PA. Otherwise, in April, the slide deck will be updated to include those other claim stats on antipsychotics and stimulants based on age range. Are there any questions on MDWise? All All right, thank you so much. Back to you.
All right, thanks, Nick. Next up, we have Cindy Urig with MHS. Cindy.
Hi, good morning. Here are the numbers for MHS, and it's just like CareSource, it's the raw data. I'd just like to make a couple comments on this slide. Our PA approval rates are relatively steady for the last 3 quarters. There's really not a whole lot to discuss. But if you look at the PA volume, the stimulants, they are mimicking Q1, and then they kind of come back in Q3 and Q4 of 2023 to be the same. I believe that's due to the start of school as well as the shortage in the market for the stimulants. So we've got a lot of providers just trying to keep people on these medications and moving things around. When I look at the percentage approvals, just as a comment, they're within 1 to 3% from the previous quarter. So the reviews seem fairly consistent for MHS. Do you have any questions for me?
All right, thanks, Cindy. Next up, we have Monica Blankenship with UHC. Monica.
Good morning, everyone. Just like everyone else presenting our UHC PA stats, and unlike everyone else, we are a little bit crazy when it comes to our trends graph, as you can see. Just a couple things to note, we have such a small volume, so you can see some of these don't even get above 20 PA requests in total for the quarter. So 1 or 2 approvals or denials can really make our graph look skewed. I'll also note for our antipsychotics, I believe we're the only MCE that requires lab values similar to what fee-for-service does. And we do see a lot of antidepressants that get denied because the prescriber said, I will get labs. We give them that short-term authorization to have the duplicate antipsychotic. But then once they run out of that short-term authorization, they apply for a new PA. There's still no labs that have been gotten at that time. So we do see a little bit more in the denial range because of that. However, when we look into that as well, we see that upon denial that we will get subsequent approvals because they will provide that lab value and maybe they just selected the wrong thing. So just something I want to call out there, but otherwise, you know, all of these values, none of them are concerning because we do look at these very closely. We just see a little bit more craziness because of our low numbers that make us not really able to study out. Any questions? Okay, thank you.
Thanks, Jessica. All right, next on the agenda, we have the Wards and Fosters Guideline Development Update as a standing agenda item. Any updates on this that anybody wanted to discuss?
It is on the DCS website, the 2023 guideline. I think we brought that up at previous meetings, and they were having some issues getting it put on the actual website, but it is up now for prescribers to utilize.
Great. Any other comments? All right. Any items that we needed to discuss on the concurrent use of opiates and benzodiazepines? I don't think we have any, but anything from anyone else? All right, then we will move on to public comment. Let me see. I thought I saw a couple things come through in the chat. So I did see that Daphne Nee was on from Biogen. She just said she's available if there's any questions on Zurzuvae, which I don't believe there were any. But Daphne, do you want to provide public comment, or are you good?
No, I'm good. I just want to be available for questions if there are any. If there aren't, that's fine.
Okay, perfect. Any other public comment? You can raise your hand, shoot a message in the chat box. All right, I am seeing none. So then I will move us on to old business. Any old business from anybody? Okay, any new business aside from mine before we get into mine? I'll make sure we capture agenda after we review this. All right, let's go into this new business. So just wanted to have the PA for Reserves Bay on the. So the PA for Reserves Bay, they must meet all of the following: diagnosis of postpartum depression. We've already discussed the 18 age or older. Member is within 12 months of being postpartum, and so we would need to know their delivery date. And then we already went through all the dosing, the 20 milligram capsules and the 25 or 28 for capsules for that 14-day period, and we have it in there for the year. And then the 30 is 14 for the 14-day period. And then we need to make sure that the prescriber submitted documentation of severe hepatic impairment for the 30 milligrams, or that they submitted documentation of moderate to severe renal impairment. Any questions or comments on that PA? All right, and I believe this is all the new business we have, right, Courtney? Yeah, so if I could get a motion in a second then for that.
This is Carol. I'll move to approve.
This is Wendy. I'll second.
All right, so I have a motion and a second. Ms. Lugo.
Aye.
Dr. Andreessen.
Approve.
Dr. Holvershorn.
Approve.
Dr. Knapp, or yeah, Dr. Knapp. I thought I saw he might have dropped, but he may be back. Yeah, I did see that he dropped, so I'll make sure that he's out for this. So we do still have a quorum though. Dr. Ott.
Aye.
And Dr. Powell.
Aye.
All right, we have all ayes and the one up, so that will carry. Any other new business or any new agenda items that you all wish to add to the agenda for next meeting? All right, I am hearing none. So Ms. Lugo, I will let you adjourn us out for the meeting.
I will adjourn. Thank you, everybody, for your time. Appreciate it. See you in a few months.
Bye,
Thanks,
everyone.
everybody.
Thank you.
Have a great weekend. Bye-bye.